Hi, and welcome to Swedish discussion on pain management. I'm Stephen Stanos, Medical Director of Swedish Pain Services. I've got a couple of my outstanding team members with me today. To my right is Sharon Hsu, pain psychologist at Swedish. I'll let her introduce herself. And then to my left is James Babington, is a pain management specialist and rehabilitation specialist at our clinic in Edmonds. So I'll turn it over to Sharon. Thanks for coming.
Hello, I'm a pain psychologist over at Swedish Pain Services. Welcome, everybody. And I think we're supposed to talk a little bit about why we do what we do, so I'll start with me. I really enjoy working with people. That's the reason I got into clinical psychology. And specifically with pain, I think pain is such a human experience. At some point in our lives, we all experience pain, and the ability of using tools to help people suffer less. That's something that's really has attracted me into this, and that is why I do what we do. And I also really enjoy working in a team environment in our clinic. Many good team members to work with. So that's another reason that has kept me where I am today. So.
I'm James Babington. I'm a pain physician at Swedish Edmonds. And I went into pain management after finishing residency in rehabilitation medicine because I thought it was a disease that many people have had. We've all had pain, and some people have it for longer than others. And to give people an opportunity to improve quality of life and to improve their function was really important to me. And I like working in a team with psychologists and doing procedures. So a little bit of everything.
And I'd like to comment too. I'm also a pain medicine specialist and a rehabilitation doctor. And what I learned from being a rehab physician was there's so many different tools you can give patients with chronic pain, whether it's physical therapy, psychology, exercise, helping them with medicines, and even just educating them. So that's always been where I've kind of had this connection with patients. And I think all three of us can agree that patients that come all have individual stories, and the stories are interesting, and you get to know patients in a different way and kind of see them progress, which I think is what's gratifying for me as a pain physician. So we're looking forward to having a nice discussion about chronic pain in general.
Well, thank you all for joining us. And I want to invite anyone that's tuning in to submit your questions in the comment section, and we will get to them live. But let's start off talking about how you classify chronic pain and when should someone seek help for it.
So we all know what pain is like. We've all had painful experiences, if it's a broken arm or it's a surgery. And that's more acute pain. So that's the kind of pain that gets better. And sometimes when pain persists for more than 3 months, we call it chronic pain. And that can be something that's an injury that doesn't heal, or there might not be a surgery to treat it. And that kind of pain we treat a little bit differently, and we take a longer view on how to improve function, minimize the suffering from that pain, and use some of the different tools that we've talked about, like injections or surgeries or medications, therapies, psychology. But we have a lot of tools that we can use, and so looking for help when that pain starts is really important.
Okay.
And I would just say too, with chronic pain, like James alluded to, there's really a lot of changes in the nervous system. So that initial, let's say, wrist injury, in many patients with persistent pain, the whole pathway from the wrist to the spinal cord to the brain and how we perceive pain changes, and that's why it becomes such a challenge. And then over time, unfortunately, can lead to depression and anxiety and things like that. So chronic pain isn't just acute pain that lasts a long time per se. It's just there's a lot of changes in the nervous system that make it such a challenge. But then that's why the treatment has to reflect those changes in the nervous system. And maybe Sharon can comment as best as a psychologist, because what you deal with and what we see with our patients more on the psychological, the other suffering that they go through.
Right. I think one of the things that pain sometimes does for people is, it changes the way people regulate emotions, hence the depression, anxiety, but really kind of beyond that, what I hear more than anything is frustration, sometimes even anger. A lot of these strong emotions, one that may have toward oneself, because suddenly you're finding that your body is not the body that you know anymore. There are many things that you would love to do, but you just can't, or you can't do it the way that you used to. So it's a big adjustment. And so that's where I think psychology, behavioral health can really be helpful, is helping people identify and acknowledge the adjustment that one may be going through, and also working on some tools for regulating your emotions differently. So things like diaphragmatic breathing, mindfulness meditation, various tools that could be really helpful for emotional regulation, I think really comes into play, as far as longer term pain management. Yeah.
And I would just comment too that the medicines, a lot of people think pain, we use medications, and we can do that. And the medicines work. It's just a part of the bigger picture and what we're doing. But medications have different effects. And so we can use anti-inflammatory medicines for a certain type of change in the body. We can use opioids, which affect kind of blocking pain signals. But there's also antidepressants that can work not only for mood, but for pain. James, I don't know if you want to comment on other types, because it does get confusing because we're using different medicines for different reasons.
And I think maybe not to get too into the weeds about the different kinds of medicines, but we believe our patients, right? That's the beauty of choosing a specialty. We believe our patients have pain. We know they have pain, and we want to use all the tools that we could think of to help them. And so one thing I always hear patients worried about is they say things like, well, you think I'm crazy, or why am I seeing a pain psychologist? And really we want to use the full spectrum of what's available to help your central nervous system, which is where we know the pain exists, and how we can treat that. And that includes anticonvulsant therapies and anti-inflammatories and opiates. So there's a broad spectrum. And if we focus just on one thing, then we end up failing.
Okay, great. So Dr. Stanos, you mentioned acute pain. So what's the difference between acute and chronic pain?
Because that's a good question. And I think most of us have had acute pain. Acute pain usually lasts for a number of days or even seconds. If you think you get up in the morning and you stub your toe and you have severe pain, and you may swear or do something in the morning and limp around for those couple of seconds, that pain and the trauma to your skin is kind of a warning sign to your nervous system. So it's a normal part of our body that we need that kind of sensory feedback. But normally, even if we did have a small injury, our body can heal that. And so whether we use ice or heat or use medications to help with the inflammation, our body has a great ability to heal. And so acute pain usually has a short course, whether it's weeks or days, maybe less than a month. But over time, unfortunately, some of our patients can develop chronic pain where there isn't healing, or there's a certain amount of healing, but there's changes in the nervous system and how we kind of process that pain. And that's why we see changes over time with the chronic pain, that it affects mood and all these other things, because it's so persistent.
So we actually have a question from someone that's tuned in. What is your experience with spinal cord stimulators as a way to deal with chronic pain?
Okay. James, you want to answer that? James got experience there.
Spinal cord stimulators can be very effective in alleviating pain. They're a device that's implanted next to the spinal cord after someone's had an injury or surgery to their spine. And it can alleviate pain, particularly in the legs and sometimes in the back or neck. We also use it sometimes for CRPS, or complex regional pain syndrome. The therapy can be effective. We like to exhaust all of their therapies. If we do a trial, it works well.
Can you explain, James, that patients can have like a trial first, and then there's a surgical implant that takes place?
The spinal cord stimulator involves a small surgery that we do. We usually do a trial first, so we thread a catheter in the spine, and the patient has that catheter taped to their skin for about a week, and we test to see if the technology works. And if it does, we'll do a surgery where we implant one of those leads in the spinal canal, and then a small pulse generator, or a small little device about the size of a matchbook that powers the device, and you have a remote control, and you can turn it on and control how the stimulation pattern works.
It's been a huge area of growth in the pain community, and the technology is evolving, and it'll continue to evolve. Yeah. And so it's been a big kind of added benefit for many patients. And many patients have a spinal cord stimulator, but also are on medications or doing physical therapy, and it's part of their treatment program.
Great, thank you. So a question that came up are, what are some of the problems related to opioid use for pain management? This is a topic that a lot of people are talking about.
Yeah. Well, I would just comment. I mean, first, there's obviously a huge crisis of overdose epidemic in the country, but it's kind of there's two different really public health problems. There's the undertreatment of pain, and with 50 million people that suffer with chronic pain. And on the other side, we have this overuse of prescription opioids and heroin and illicit fentanyl, which has caused thousands of deaths in this country. So there's been this work in the last couple of years, especially, to try to balance how do we provide the pain care the patients need, whether they need to be on opioid medications as part of their treatment, and then at the same time, how do we limit the risks for people developing an addiction problem? How do we limit over prescribing medicines or giving people too many medicines when they go home that they don't use and that someone can get with a substance abuse problem? And then there's a lot of interventions at the state level to try to help people with addiction, and how do we help those patients. So it's very complex. It's been a challenge for pain physicians in patients with pain. Many of our patients with chronic pain may have an addiction problem. They may there's a lot of overlap between that, so it becomes challenging for physicians. But hopefully there's been more judicious use of medicines, and that's been helpful. But we really need more resources for patients. And I don't know if Sharon, if you want to comment about addiction and with opioids and those issues.
I think that's, as Dr. Stanos was saying, it's really a complex issue. Where I see it in our practice, oftentimes it's mixed with a lot of anxiety about pain. Anticipating that certain movements is going to be associated with pain, and so that's one type of anxiety. Another type of anxiety is anxiety about medication usage. Literally counting down the moments till the next time that someone is scheduled to take certain medication, and so to me, to kind of effectively, address the suffering, looking at ways to help people, again, become aware of the anxiety, become aware of the behavioral patterns, how you cope with this anxiety, and how to improve the coping. I think that's a huge piece of it. Another piece that we sometimes see in our clinic is that, as people become really desperate, about pain management, and they feel like they have no options, they turn to, alcohol, for example. I've just talked to, somebody this week about the fact that, having more drinks than usual really kind of helps a person sleep, from their perspective, and really kind of decrease the pain to some extent. So that's another example where, I think it's so easy and for somebody to develop problems when they feel that they're, really desperate spot with pain management. Yeah.
And I'll just comment, there's patients that have substance abuse problems and develop opioid addiction that didn't start with pain, and there's some patients that maybe started an opioid abuse problem or addiction problem be related to pain. In our clinic, we have an addiction specialist, Greg Rudolph, who sees patients. Many of those patients that have an addiction problem, let's say to opioids, can get converted to what's called buprenorphine, which is a medication that they can take that kind of prevents them from craving opioids. And he uses acupuncture and kind of our treatment program with non-pharmacologic management as well. So there's options too. We've had many patients that have developed chronic pain, then developed an addiction problem. We've treated their addiction problem and then taught them other skills to better manage their pain. So again, though, it's very complex because patients have really different needs. I don't know if you want to comment too on what dealing with patients with opioids and trying to determine what to do.
I think the hardest thing for any of us to deal with, including patients, and frankly for doctors too, is what's the right thing to do, right? We all hear about opioid crisis, and we want to take good care of patients, but it's also a dangerous time because you can get harmed. And how do you differentiate when a patient's benefiting from this or not, or patients misusing medication or not? And I think we're all learning this together. And so hopefully as time goes on and we get more information and more understanding, we'll be better able to understand which medicines work best. And some of those might well include opioids.
And I think there's been a lot too, and just with guidelines, and some patients are getting pushback because pharmacies are refusing to fill medications. There's been changes in some of the state laws and federal laws, which in some cases has pushed past the normal physician-patient relationship and our ability to make what we feel is appropriate for patients. So we're hoping the pendulum's going to swing back to the middle, and we'll be able to balance appropriate care for patients and being good advocates for our patients, and then not letting an outside group kind of mandate what patients should do, and not really understanding the patient's problems.
Yeah.
Related to this, I would just like to say that in our clinic, we regularly discuss with patients kind of the stigma that's associated with having chronic pain, as well as being on certain medications. I can't tell you how many times People openly acknowledge, their pharmacists are looking at them differently, and they're being judged. And, this is the same pharmacist that they've seen for 10 years. And now suddenly, because of the climate that we're in, they're being treated differently. And there's a lot of shame and a lot of guilt and embarrassment associated with that. Again, just to me as a psychologist, just kind of seeing that as compounding factors, compounding stress that can, certainly make pain worse, that can make help seeking even more difficult than it already is. So I think, for us, we really try to work on acknowledging that for patients and with patients. So hopefully they can feel more comfortable with getting help. We also, related to that, talk to people about how to talk to family and friends who are really concerned about certain medications that you're on, how to educate yourself so you can educate them. About why you are on this treatment course that you're on. So I think those are some really important factors to consider.
Yeah, definitely. Definitely. So in some of your responses, you talked about some of the non-medicinal approaches to chronic pain. Can you just go over some of those again and why those are utilized?
Yeah, I mean, we have just in a big picture in our treatment program, we do procedures, and we alluded a little bit to interventional procedures like neurostimulation, like spinal cord stimulators, but we do X-ray guided spine injections, which are common for people with back pain and neck pain. We also have what's called interdisciplinary or multidisciplinary care, where patients come to our clinic, and we have kind of a team approach, and Sharon can discuss this more, but patients are there for multiple hours a day, where they get physical therapy, psychology, occupational therapy that works on teaching them how to function and adapt their posture and pace their activities. We also teach relaxation, which is a different way to give people more tools to manage their body. We have nursing education, and over that week, they will be in our clinic for 15 hours, in some cases for a month, but learning all these different techniques, and then they're working with the physician on their medications. But Sharon can comment on our pain rehabilitation program. But we see a lot of patients for medication management, individual physical therapy that they may need. And James' clinic he's helping to kind of supervise patients in more kind of a la carte treatment. So if you want to comment on yours first, and then Sharon can talk about the program.
Well, a lot of times patients receive physical therapy or occupational therapy as an outpatient, and we use an a la carte model to do that. The interdisciplinary program is a lot more powerful, right, because the messaging is the same, and our providers all talk to each other, and there's a lot to be said for the interdisciplinary treatment program. So we're hoping that we can start to expand what we have downtown and out further.
Mm-hmm. Sharon, if you want to just comment on the program part and what you focus on. So.
Yeah, so the whole program really kind of rests on this idea that when you're dealing with chronic pain, you should be paying attention to how your nervous system is functioning. As both of the doctors have alluded, chronic pain really kind of affects the nervous system, and how pain happens in the body has a lot to do with nervous system regulation. So, resting on this, idea, all of the therapies that we have, from physical therapy all the way to relaxation therapy, is geared toward helping people identify, appropriate type of movement and activities that will be calming for their nervous systems, so they can kind of move with pain, breathe with pain, meditate with pain. That's another thing that we do. So that's I would say kind of the full range here. Again, working on promoting better nervous system regulation. And one of the things I think is worth pointing out is that because of pain is such a devastating experience for people, a lot of people become fearful toward movement, and with chronic pain, the less you move, the worse it can be, in the long run. So, our physical therapists, occupational therapists, are really focusing on identifying slow, breathe with pain. It's just, so valuable when people are in those really kind of, suffering state.
Yeah, and I think Sharon brings up a good point. We have a lot of patients that have had maybe physical therapy for their back pain, but they had too much pain and they weren't able to keep up with their exercises. So when our physical therapist works with them, we're still working on strength and their core muscle strength, but then they're also learning how to breathe while they do their exercises, and they're understanding kind of how fear can make their pain worse. And so a lot of times, even though they maybe have failed PT in the past, if we approach it in a different way, those a lot of times they can get a lot more out of it, and then trying to integrate it into their lifestyle. That's probably the toughest part. Is we teach these different techniques, and how do we get our patients to integrate those things, which takes time and a lot of education. So
yeah. So we actually got a question. I suffer from pain every day after round 2 of breast cancer. What natural painkiller can I use? I don't take pills. I don't drink alcohol. Every day I have pain. So what can I do?
Well, I just thought of natural painkillers. I mean, exercise in itself, there's just been really a lot of research in that area that exercise, kind of increases your own body's kind of endogenous opioid system. And so the effects of exercise, besides the cardiac effect and helping you breathe better, actually can help decrease pain. And so, regular exercise can be helpful. It's just how to balance and how to slowly increase that. You might want to comment on other.
I think therapeutic touch is something else that's come up that a lot of people enjoy and benefit from. Things like massage therapy would be a natural sort of thing to think about. It's hard, obviously, to comment on this particular case. Specifically, acupuncture would be another option to think about that's not medicinal.
Yeah.
So with exercise, I know that one of the things our PT would recommend is trying to get a stationary bike. From Goodwill, from other thrift stores. Usually it's not too expensive, and just try to work even with 5 minutes on the bike and see how you feel and kind of build yourself up that way. If that's not an option because of space or funding, I would go to the Seattle kind of Parks and Recreation's website. I recently actually found out from my patients that there are many local community centers sometimes would just be free, and there would be a gym space there. There would be some equipments there. That would be a way of accessing, some regular ways of exercise as well. Yeah.
And I do think it would be good. And like James said, I'm not familiar with the patient and their details, and I'm sorry that they're struggling. It's very common. We have patients that tell us they're fearful of medicines or fearful of a certain type of therapy, and so the education on the part of the clinician can be very helpful, because there are medications that can be very helpful to help decrease pain related to sometimes you can have developed nerve pain after a mastectomy or breast surgery. There are different medicines that, hopefully done in the right way and maybe explained, could be an option for this patient, and we would hate to not offer something that could not be of benefit. But there is a huge increase in the use of nutraceuticals that have been helpful for some patients, but I always tell patients to talk with their primary care doctor. They'd be surprised there are some other options out there.
Great. And Sharon, you mentioned mindfulness and breathing to help kind of get you through pain. Can you give an example of what that looks like in terms of mindfulness?
Sure. So I think mindfulness has, enjoyed its popularity and, since the 80s, and more recently actually with the area of cancer. There's been some really good research showing that, mindfulness meditation practice can help promote coping, build resiliency, which is really important in patients that are going through cancer treatment or cancer survivors long term. So mindfulness, one definition is paying attention to your, experience with a non-judgmental attitude, moment by moment. So, in our clinic, we often teach people to close your eyes and maybe you put one hand on your abdomen, and one hand on your chest, another hand on your abdomen, and just starting to actually become aware of your breath. This might seem really basic, and what ends up happening is a lot of people through this practice are finding out that when they're feeling stress, which can be related to pain, they're holding their breath, or they're breathing in a really fast pace. So this is a really great starting point of becoming aware of how you breathe, right? And if your mind drifts it off to to-do list, childcare, all those great things, bring it back and over to the flow of your breath, to the sensations of breathing, and to kind of the rise and fall of your abdomen, right? So that's the easiest way for somebody to start a mindfulness practice, is just by learning how you breathe, and oftentimes that's really informational.
Yeah.
And with going back to the nervous system regulation piece. chronic pain can be a chronic stressor. And if it is indeed a chronic stressor, that means, your nervous system is often on kind of what we call the fight or flight state. With that, actually, one of the most helpful things is starting to regulate your breath. Breathing at a slower rate, regular breathing actually more from the abdomen, and rather than kind of the shallow breathing mostly happens in the chest and above, can be really useful.
Yeah, I think it's an understatement that because our patients, many times when we teach them relaxation, they haven't really realized it. And then once you teach them that, just their breath itself, that awareness, then they realize that they can actually control their body. And it's a lot of times the first entrance that they can have more control of this, where in the past, we as clinicians have just given medicines or given them something to do, whereas this way they're taking active control. And I'm always amazed by the patients who are like, why didn't I learn the breathing sooner? Yeah, because all of us get in bad habits, and then pain can make that worse. So something as simple as breathing can be really helpful for patients.
Yeah.
And stress management, because then unfortunately if you can't control your stress, that also plays into misusing medicines or not being able to function like you'd like to.
Right. So there are a couple of apps out there that are, free and really effective for kind of getting started with your, breathing practice. One is called Breathe to Relax. It's an app that actually created by the Veterans Affairs Department, and the other app is called Breath Plus. With basic, if you're just accessing basic functions, you can actually get a lot, and it's free. So I would recommend looking into, one of those two. If you're not working with, a behavioral health provider, if you want to just be trying this on your own tonight, even before you go to bed. Yeah.
Great. Well, thank you all so much. Is there anything else you'd like to touch on for the audience before we wrap up today?
Well, if we talked about in neuromodulation like spinal cord stimulation, we touched a little bit upon medications for pain. We talked about pain rehabilitation. For some patients with very severe pain, and we see a lot of those patients in our clinic. There's also intrathecal opioids where patients get medication that's kind of pumped the opioids into their spinal cord. So there's really a huge kind of range of treatments you can give patients. So it's really important that they see a pain provider or see their primary care provider first, and then they can help guide them to the right type of specialist. But we only had a couple minutes here to talk about the treatments for pain, but there's really a lot out there for patients. When I get frustrated, I can really feel kind of sorry for patients, is that many times they're not aware of everything that's out there. Right. And so it's the education key is important. And so they really, I think, should start with their primary care provider, hopefully, and they have access to pain management so they can get that kind of expert help, including behavioral health. I mean, one thing we didn't really talk about is many of our patients don't have access to behavioral health and psychology and counseling and relaxation training. And so hopefully those things are going to change, but that's always something else to be thinking about. I don't know if, James, if you have any other comments.
I think thinking about patients suffering from pain and how we take care of them, and one of the biggest things we can give patients is an internal locus of control. When we talk about that, it's that you have control over your body. We take our bodies for granted, and I learn from my patients every day how lucky I am from things that they're not able to do and things that they've lost. And so when we can do some of these exercises, we're taking the control away from doctors giving you medicines or fixing something that can't be fixed, and giving you some control over your body and recognition of what your body can do. And so I think it's really important to kind of access all the tools we have to help treat pain.
One thing that I would say is that, I think having pain in the body isn't necessarily the main problem. From my perspective and in our practice, I think it's how patients relate with pain. How patients respond and how patients cope can really make a tremendous amount of difference. I'll just say that I've seen plenty of people, going through some of the therapies that we have. Some people feel that pain is getting better. Some people don't necessarily feel that way. One thing that's really clear to me is that if you can improve the way in which you cope with pain, that can actually give you better quality of life with what you want to do and your family members and your friends instantly. So that's something that I want to encourage people to focus on, not necessarily, how much it hurts, and also kind of the numerical scale that we usually talk about, 0 to 10. I know a lot of people feel very annoyed about that. I really empathize. But focusing more on your personal relationship with pain and also how you cope, I think that can really make a difference. Yeah.
Great. Well, thanks again to all of you, and thanks for everyone that tuned in today. And we'll see you at our next Facebook Live.